Let us move on to the second presentation of part 3. We have Dr. and Professor Anand Rohatgi, Internal Medicine Division of Cardiology, University of Texas Southwestern Medical Center. He'll tell us about HDL and cardiometabolic health. Please give Doctor a big round of applause.
Thank you. It is a privilege and an honor to be invited by this conference symposium and the sponsor, Radel, to give the talk on HDL and cardiometabolic health. And many thanks to especially speaker Dr. Carrie Ann Rai, who helped pave the way of setting the tone and format and some of the content for the conference. These are my disclosures. So, of course, heart disease is the leading cause of death, but the topic here is the role of HDL in overall cardiometabolic health. And as you can see here, not only heart disease, but diabetes, hypertension, and kidney disease also are leading causes of death. So cardiometabolic disease is a highly impactful problem and an unmet need. With specific focus on atherosclerosis, most of the investigations have focused on limiting influx of ApoB-containing particles to limit the plaque development, and that has been met with remarkable success. So things like low saturated fat in diet and statin medications in particular reduce the overall plaque burden. But we've probably hit a maximum yield from that strategy, and yet heart disease remains the leading cause of death. So what has emerged is an increasing focus on being able to remove cholesterol from the plaques, called cholesterol efflux or reverse cholesterol transport, to be able to prevent the initiation of plaque and also even regress plaque formation. And a lot of this effort has been focused on HDL and ApoA1 containing particles. So with respect to HDL cholesterol levels, HDL cholesterol, as Dr. Rai nicely summarized in her leading slides, is a powerful risk marker for developing atherosclerotic cardiovascular disease. HDL is one of two biomarkers in the main risk equation that's used in the United States, the pooled cohort equation, as well as the European score risk calculator. To predict a person's risk for developing ASCVD over the next 10 years. But HDL cholesterol levels do not reflect all of the quality and functionality of HDL. So while it's a powerful marker for predicting risk, it doesn't tell precise information on how HDL is working and how you can manipulate it. So what I'd like to do today is go over several main concepts. One is the diversity of structure and function for HDL, the role of HDL function in risk assessment, the relationship between HDL and blood pressure, and HDL function in metabolic syndrome. So again, some overlap with what Dr. Rai nicely summarized earlier is looking at lipoprotein particle structure classified by size on the x-axis and density on the y-axis. So you can see all of the ApoB containing lipoproteins in the top right of the graph. You have very low density VLDL, intermediate density IDL, and low density LDL. And then on the bottom left, the smallest and most dense particles are the HDLs, the high density lipoproteins. And hopefully what you can appreciate from a figure like this is even within each subclass, the remarkable heterogeneity and diversity of different types of particles within each subclass. So with LDL, the story is quite simple. Every LDL particle has one ApoB containing protein on it, and the cholesterol content of LDL is closely correlated to the particle number and the ApoB concentration. And that's why you can use LDL cholesterol so easily when it comes to predicting risk and as a therapeutic target. But HDL doesn't work that way. So HDL cholesterol levels are weighted to the largest subclass of HDL particles. Those are the yellow ones in the figure here. And you can see that while HDL cholesterol is weighted to the largest subclasses, if you just simply count the numbers of particles, that type of biomarker, that type of metric equally weights across all of the subclasses of HDL. And if you look at large studies, the correlation between HDL cholesterol and HDL particle number is moderate. It can be 0.4 to 0.6 depending on the study population. In addition to that modest correlation with particle number, the main protein on HDLs is ApoA1. And unlike LDL, where there's one ApoB protein per particle, for HDLs it can vary, and it can vary typically from 2 to 4 ApoA1s per HDL particle. So that the ApoA1 concentration also only moderately correlates with HDL cholesterol content and HDL particle number. So while these are all related metrics of HDL composition, they're only moderately correlated with each other, and so they each are complementary when it comes to assessing HDL composition. With respect to the proteins, like I said, ApoA1 is the main protein on HDLs, but it's not the only one. This is another difference between HDLs and LDLs, where LDL, the number of proteins is in the 20 range, about 20 proteins on the surface of LDL particles. There's a 10-fold increased number of proteins on HDLs. Over 250 distinct proteins have been described on HDLs. And since proteins drive function, that remarkable diversity and number of proteins on HDL supports the concept that HDL has a diversity of functions, and that you could see represented in this cartoon to the right. And with respect to HDL functions, while there are many that have been described, I'll just highlight 3 that have been the most studied in this figure here. Perhaps the most important and most studied function is its anti-atherogenic function of being able to remove cholesterol from the periphery, from cells and tissues into the circulation. This is called reverse cholesterol transport. And the first function, the first step of that is called cholesterol efflux, where cholesterol moves out of cells, in particular macrophages, from the walls of the arteries into the circulation and then out of the body through bile and feces. Another main function is HDL's ability to manipulate inflammation, and it can do this through a variety of cell types, in particular through macrophages and endothelial cells. And its effects can be anti-inflammatory, but it can be pro-inflammatory as well. And in the setting of states like acute infection, this is in fact a protective function. And then the last one to highlight here is its ability to block oxidation and its anti-oxidative effects, in particular the ability to block the oxidation of LDL particles. Oxidation of LDL can render it highly atherogenic, and it's the oxidized LDL that starts to begin the plaque formation. So with that background, I'd like to move into the role of HDL function in assessing cardiovascular risk. So as I had mentioned before, HDL particle number is only modestly correlated with the cholesterol content, and it equally weights across all of the HDL subclasses. So we hypothesized that this would be a more reliable biomarker for predicting cardiovascular disease risk. So we undertook a study in 4 different population-based studies, 3 in the United States, the Dallas Heart Study, or DHS, MESA and ERIC, and then a European cohort study called PREVENT. And in summary, this constituted over 15,000 research participants. Median age was about 56, about half were women, and about 22% were African American. Those were from the United States cohorts. And in the forest plots on the left, you can see the hazard ratio for the top versus bottom quartile of HDL cholesterol for predicting the endpoints listed on the left. So if you just focus on what's highlighted in pink, for ASCVD, that's the risk of heart attacks and strokes. For HDL cholesterol, the top versus bottom category led to about a 21% reduction in risk. The hazard ratio was 0.79. And then if you move over to the right forest plot, you can see that when you not only adjust for risk factors, but you now account for the particle concentration, the relationship between HDL cholesterol and ASCVD is completely attenuated. And what that meant to us is that the risk prediction information that's carried by HDL cholesterol is explained by the information in the particle number. We then flipped the analysis and looked at HDL particle number as the primary biomarker. And on the two forest plots on the right, you can see that the left one, now you're seeing the hazard ratio of the top versus bottom quartile of HDL particle number for predicting ASCVD. And you can see here, adjusted for risk factors, there was a 36% risk reduction for increasing HDL-P. So the hazard ratio was 0.64. And when we include HDL cholesterol levels, that's the rightmost forest plot, there was no change in the point estimate for HDL particle number. The top versus bottom quartile remained at a hazard ratio of 0.64 or a relative risk reduction of 36%. And to what that meant to us is that the risk prediction information carried by HDL-P was not explained by the cholesterol content. And to us, this meant that, at least from a risk predictive strategy, that HDL-P was much more superior than HDL cholesterol levels in predicting ASCVD. So moving from particle number to function, as I mentioned before, one of the main functions is the ability to remove cholesterol from the periphery, called reverse cholesterol transport. And cholesterol efflux is that first step from the cells, in particular macrophages. So up until the point that we decided to study this, the studies were mostly in the basic science setting and had been done in limited numbers of humans. And then the only large study that had been done to date in humans was cross-sectional, correlating prevalent coronary disease to HDL function. And so what we thought was important to explore was the ability of HDL function as a biomarker to predict the development of ASCVD in the future. So we adopted a longitudinal design in the Dallas Heart Study, where we took baseline levels of cholesterol efflux measured in the ex vivo assay that's depicted on the left, where we incubated macrophages with labeled cholesterol, and then took every participant's ApoB depleted plasma as the acceptor and quantified the movement of cholesterol into the medium as cholesterol efflux. We studied this in almost 3,000 participants who were healthy without heart disease in the Dallas Heart Study. The median age was 42, so they were young adults. A little over half were women and half were Black or African American by study design. And we undertook cross-sectional relationships with metabolic and lipid phenotypes, as well as a longitudinal assessment of the relationship between baseline cholesterol efflux and the incidence of developing ASCVD. In this case, defined by the incidence of endpoints like MI, heart attack, stroke, coronary revascularization, and cardiovascular death. And what we found was quite striking. We found that over about 9 or 10 years of follow-up, there was a graded inverse association between baseline cholesterol efflux and incident ASCVD. That is, the lowest levels of efflux, quartile 1 in red, had the highest levels of developing ASCVD events, and the highest amounts of efflux in green, quartile 4, had the lowest events. This was the first report of looking at any HDL function and linking it with incident cardiovascular events. From there, what was reassuring was that many studies recapitulated our findings across different populations, different continents, different labs assessing HDL function. So our study is in white at the top. This was a low-risk, healthy population showing an inverse relationship between efflux and CAD. EPIC Norfolk was also a low-risk study, but in Europe, in yellow. The third depicted here is called LURIC, which is a high-risk European study, people undergoing coronary angiography for symptoms or heart attack. And then the fourth that I list here is a Chinese high-risk cohort, also people undergoing coronary angiogram. And I don't list all of the studies that have been published to date, and I would say in aggregate about 80% of large-scale studies looking at cholesterol efflux or any function have shown this inverse association with the incidence of ASCVD. So overall, very consistent and reproducible. We then went further to understand what the clinical relevance of this might be, since we already have a number of biomarkers we can use to refine risk. In my clinic, I often use something called a coronary calcium scan, which many of you may be familiar with. It's a simple CT scan that looks for calcium deposits in the arteries, which is a reflection of plaque. And people with coronary calcium have higher rates of developing MI, obviously, as if they have plaque. So we restricted our analyses in the Dallas Heart Study to only those who already had coronary calcium at baseline, because that already predicts that these individuals are at higher risk, and maybe other biomarkers may or may not have additional risk refinement capabilities. So this white line is the overall group of people with baseline coronary calcium over 9 years, developing ASCVD. And interestingly, those who had low efflux, less than the median, although they already had coronary calcium, had even higher rates of incident ASCVD. And contrasted that to people who were above the median, people who had higher levels of cholesterol efflux, there was a 60% reduction in the incidence of ASCVD, despite the fact that everyone had baseline levels of plaque. Everyone had coronary calcium. So from a biomarker perspective, this told us that there may be actual clinical relevance in using these kinds of markers in predicting risk. We went on to show this the same for CRP and family history of heart disease and Lp(a), that regardless of all of those risk factors, cholesterol efflux as a main HDL function still predicted risk. The second HDL function that I'll highlight for the talk today is anti-inflammatory capacity. And this was done by UT group. And what they did is they looked at the ability of HDL to suppress VCAM production from endothelial cells after being stimulated with TNF-alpha as a readout for anti-inflammatory potential. And they analyzed this in a European cohort called the PREVENT study. They did a nested case control of over 300 cases and 300 controls, and they found a very nice inverse relationship between the anti-inflammatory capacity and incident ASCVD. In the table to the right, you can see the hazard ratio for HDL cholesterol adjusted for risk factors was neutral. So HDL cholesterol did not have a predictive risk for incident cardiovascular disease, but the function marker, anti-inflammatory capacity, did a hazard ratio of 0.74, meaning that there was a 26% relative risk reduction. And even when you adjusted for efflux capacity, you could see that this function had its own independent ability to predict risk. And simultaneously, efflux, which was done in the same study, also was able to predict risk independent of the anti-inflammatory function. So that these two functions have complementary risk predictive abilities, that they were giving different pieces of information on predicting risk. In terms of the proteomics for HDL, a lot of work has been done on understanding not just ApoA1, but some of the other proteins that go into the HDLs and how they can be used to predict risk. This is a commercialized assay developed by Quest, where they isolate ApoA1 and they use mass spectroscopy to quantify 5 proteins on ApoA1 containing lipoproteins, and they have a proprietary algorithm to come up with a score called PCAD. And what they were able to find, show was that among people going coronary angiography, a higher or worsening proteomic score for HDL associated with more severe coronary disease. And they also went on to show that more people ended up dying with a higher score than those who had a lower score. Another way to look at this in terms of proteomics is to say not what's the overall abundance of each protein that's on HDLs, but to think about HDL subspecies that either do or do not have a specific protein. So in this case, they looked at ApoC3, which many of you may know is a very important protein in terms of cardiometabolic health, especially for triglyceride levels. And what they did is they quantified the amount of ApoA1 that had ApoC3, and that was in the black, that was dysfunctional. And the ApoA without ApoC3 was in the white, and that showed a nice inverse association. So if you can separate HDL subspecies by the presence or absence of specific proteins, in this case ApoC3, but they were able to show this with some other proteins, you can differentiate risk. So moving to the role of HDL function in hypertension, the same cohort, the PREVENT study, which is a European cohort, was able to show that HDL cholesterol levels are associated with the risk of developing hypertension. The higher the HDL cholesterol, the lower the risk of developing hypertension in the future. And others have already described this today, so I'm not going to spend too much time on this for the sake of time, that there are a number of different mechanisms by which HDLs can impact blood pressure in the vasculature, which is nicely summarized in the cartoon here, and also reviewed by some of the other speakers earlier today. One study I would like to highlight that helps contribute to the fact that if you manipulate HDL, you can actually affect blood pressure was this animal study where infusion of HDLs in an animal model actually led to lower blood pressure. And it was found that the effect of this was dependent on SRB1 mediated effects on the vasculature. So this is, again, complements the studies that was just presented by Dr. Cho earlier in zebrafish, also in humans, that there is an effect on blood pressure when you can manipulate HDL. And the last piece of the story is the relationship with HDL function and insulin resistance and metabolic syndrome. So in our own study, we had the opportunity to cross-sectionally link HDL function to metabolic syndrome. And what we found was we did two different kinds of cholesterol efflux assays. On the left is cholesterol efflux using a classical radio-labeled tracer for cholesterol. And on the right was efflux using a fluorescent label for cholesterol. In fact, they're quite different in how they behave in the assays and also how they predict metabolic risk. But intriguingly and reassuringly, what you can see here is that higher levels of efflux, if you look at the overall row at the top of the forest plot, predicted a 29% reduced prevalence of metabolic syndrome, and increasing amounts of cholesterol efflux from quartile 1 to quartile 4 was associated with a graded reduced prevalence, down to 60% reduced prevalence of metabolic syndrome. So we were able to show in a very large, healthy population that was diverse with respect to sex and race, as well as metabolic factors, a very nice relationship between HDL function and metabolic syndrome. So in conclusions, HDLs are diverse.